Hello, ladies and gentlemen. This will be a relatively brief talk on intrauterine resuscitation. Now, if you watched my lecture on fetal heart tracing, at the very end you saw me refer to something very briefly called intrauterine resuscitation. And what this is a series of steps that are pretty nonspecific that we take for any patient where the fetus is showing signs of obvious distress. Now, having an abnormal fetal heart tracing does not necessarily mean fetal distress. Okay, only 50% positive predictive value for an abnormal fetal heart tracing showing fetal compromise. So that means out of all the abnormal fetal heart tracings, only 50% of those fetal heart tracings actually indicate fetal compromise. But you don't necessarily know. That's the problem. So fetal heart tracings, well, they're valuable and they're very good at telling us that there's nothing wrong with the fetus is doing good, that it's reassuring. If you have a quote-unquote non-reassuring pattern, you don't necessarily know that there's something wrong, okay? And 50% of the time, the baby's totally okay. But when you see things like late decelerations or severe variable decelerations or severe bradycardia, we're concerned. Those are very, very sketchy things. Okay, we don't like to see those. And so a lot of OBs are going to go straight into intrauterine resuscitation. Now, if you watched the previous lecture, you saw me refer to the fetal scalp pH. Some OBs do those, but a lot of them are just going to go to intrauterine resuscitation. The advantage of fetal scalp pH is that if you have a pH of greater than 7.2, that's reassuring. And it tells you, despite all the nasty things that we're seeing on the fetal heart tracing, the baby is still doing okay. Baby's not having asphyxia or is not acidotic. So that's fine. But the thing is that that's has such an invasive nature, and the results are not greatly reliable. So a lot of OBs will just go straight into intrauterine resuscitation. So we're going to talk about this in some greater detail here. Just a reminder, if you haven't already, please consider subscribing to my Patreon page. Chip in $1 a month, not very much, but it goes a long ways, believe me. It helps keep these videos free. I've been putting these videos up for 4 years, and I want to continue making them free. So you can go ahead and type in www.patreon.com/pwbmd. I will give you this link at the end as well, or you can click the link below, which is in the description of this video. Or you can click this I button at the top right hand corner of the video, and that should bring up a window and you can click on the link there. So thank you very much for your consideration in advance. So we'll start with a snap question. We have a 32-year-old G3P2 at 40 weeks gestation presenting with regular uterine contractions every 2 minutes. She has received all routine prenatal care since 10 weeks gestation. On exam, she's 3 centimeters dilated, 75% effaced, and at -1 station with cephalic presentation, appreciated on manual exam. And so this is what you're getting on manual exam. It's not always perfect, so you have to keep in mind that these are all ballpark because you're not like looking in and taking a tape measure. So this is around what it's at. Blood pressure 115/70, heart rate 95, respirations 14, saturation 98%. Cardiotachometry is started and reveals the following. So I'm going to give you the fetal heart tracing, and I'm going to give you a question. And I want you to try and answer it, and then I'll walk you through it afterwards. Okay, so I'm going to blow this up. What do you see here? Okay, here's our question. Which of the following is the most likely cause of this fetal heart tracing? Is it A, fetal head compression, B, maternal dehydration, C, anesthesia effects, D, oligohydramnios, or E, uteroplacental insufficiency? I'll give you a chance to pause it here, and the answer is D, oligohydramnios. Now, this question required you to think through a few steps. So let's start out at the very beginning. Here's our fetal heart tracing. Mom seems totally fine. Okay, no big problems. She's not gushing out bright red blood or anything really dramatic like that. But what is up with this fetal heart tracing? It's clearly, if you look at it, it's abnormal. But let's start with where we should always start with a fetal heart tracing and identify our baseline. So our baseline is about right here. It's about 140. So it's 200 up here, 180, 160, 140. So here's right around where we're hovering. Remember, when you're checking your baseline, you have to not look at decelerations or accelerations, okay, where you're spending most of your time. And that's going to be at about 140. Okay, how about our variability? What's our variability here? Well, we're hopping between about 150 and 120. This would be about 125 during our time at baseline. So you have moderate variability here. So far so good, right? You got a baseline of 140, which is between 110 and 160. You have moderate variability. That's all good. We don't really see any accelerations here, but that's because we have something really, really wrong going on. So what are these drops? What are these called? Decelerations. And what kind of decelerations are these? Are these early decelerations? No. These are not early decelerations. Well, you might think, well, Dr. Bolin, these must be early decelerations because they're starting with the contraction and they're ending with the contraction. And the answer to that is yes, they are. But they're not early decelerations. Early decelerations are shallow. Okay, they're shallow and they're gradual. Okay, no more, or usually more than 30 seconds from onset to nadir. Okay, so they're gradual. These are sharp and abrupt, and they go down quite a bit. Okay, these more peaked decelerations are not early decelerations. Early decelerations, to give you an idea, they mirror the contractions. So they're more gradual and they last a little bit longer. So with early decelerations, they kind of mirror the contraction. So the stronger the contraction, the bigger the deceleration. But if you look, these are not very big contractions. It's only about 40 millimeters of mercury, about 30 millimeters of mercury if you start with your baseline pressure here. So they're not very big contractions at all, but you're dropping from 140 to 60. So these are not early decelerations. Are these late decelerations? No. Late decelerations start after the contraction starts and they end after the contraction ends. So they kind of look like early decelerations when they start and when they end. So they're certainly not late decelerations. Late decelerations would start after the contraction starts and end after the contraction ends. They share with early decelerations how gradual they are and also how shallow they are. The difference from early decelerations is when they start and when they end. So these are not late decelerations. Late decelerations are characterized by not only when they start and end, but by how shallow they are. They're very shallow. Okay, these are variable decelerations. Variable decelerations. And you know they're variable decelerations based on how abrupt they are. Now, variable decelerations are classified into three different categories: mild, moderate, and severe. And mild and moderate are really not a big deal, okay? But severe variable decelerations are much more ominous. So what kind of variable deceleration is this? Are these decelerations? Well, you're starting at 140 and your nadir is about 60. So you have a drop of 80 beats per minute. And our decelerations, our variable decelerations, are classified by how big the drop is. So if it's anything more than a drop of 60 beats per minute, it's considered a severe variable deceleration. Now, what if I told you that you're starting at 115, or baseline's 115, and you're dropping to 60? Okay, so you drop 55. Is that still a severe variable deceleration? And the answer is yes, it is. Now, you might be saying, well, that's only a drop of 55. I thought you said it's got to drop by more than 60. And the answer is that is one of the criteria, but the other criteria is that it drops below 70. If a variable deceleration drops below 70, automatic severe variable deceleration. So these are repetitive severe variable decelerations. Now, what are variable decelerations consistent with? Is it compression of the fetal head? No, that would be an early deceleration. Is it uteroplacental insufficiency? No, that would be a late deceleration. What about umbilical cord compression? Yes. Okay. All variable decelerations are associated with umbilical cord compression. The difference between the levels of variable deceleration is the intensity of that compression. And when you have severe variable decelerations, it means you have very severe umbilical cord compression. And the problem with that is that while the baby can tolerate some umbilical cord compression, it can't tolerate too much, and this is too much. So where we cut off severe variable deceleration, that's the level where you have too much umbilical cord compression. So that's what that's telling you. Severe variable deceleration is telling you you have too much umbilical cord compression. So this tracing is consistent with severe umbilical cord compression. And in any case where you have severe umbilical cord compression, one of the things you have to think of is umbilical cord prolapse, one of the great complications, obstetrical complications of labor and delivery. So what's the most likely cause here? Fetal head compression? No, we already ruled that out. That would give you early deceleration pattern. What about maternal dehydration? This one's kind of tricky. Okay, so maternal dehydration, we know, can make uterine contractions stronger, and stronger uterine contractions can cause more umbilical cord compression. But the reason we're not suspecting this to be maternal dehydration is because these contractions aren't very strong. Okay, you only have about 30 millimeters of mercury change from baseline pressure. Okay, that resting tone. So probably not maternal dehydration, but there's a better answer here than that. What about anesthesia effects? What would we see on fetal heart tracing with adverse effects of anesthesia? We would see bradycardia. Just like in anybody else, anesthesia causes bradycardia. It happened in mom, it happened in baby. That would be one of the adverse effects of anesthesia. Our baseline is 140, not bradycardic. Uteroplacental insufficiency? No, that would give you late decels. That's not what we have here. Oligohydramnios is the most likely cause. You could even just do this by elimination, but oligohydramnios is going to worsen umbilical cord compression because that amniotic fluid sort of cushions the umbilical cord. And so when you have a strong contraction, that umbilical cord is protected by the amniotic fluid. If you don't have enough of it, it's not protected enough, you get more compression with the uterine contractions. So oligohydramnios is the answer here. Now another possible cause, if it was given to you, would be umbilical cord prolapse. I didn't put that in here because if I put that with oligohydramnios, both of them would be likely causes. But umbilical cord prolapse, you always have to be thinking of. Now you might be thinking, well, you did the manual exam and you didn't feel umbilical cord, you felt head. And the response to that is that you can have umbilical cord prolapse even though the umbilical cord is not out of the cervix. You can have what's called an occult umbilical cord prolapse, where the umbilical cord is coming down to where it shouldn't be, and it's in between a baby part and the uterus. And when you have compression, then it's going to be all the worse because you have compression against the fetal body. And so that's called an occult umbilical cord prolapse. And we'll talk about that in another lecture. Okay, so fetal heart monitoring, remember, this is just a slide I took from the fetal heart tracing lecture. Throughout labor, it's done to ensure that the baby's doing okay, and we know that based on if the pattern is reassuring. If you have a reassuring pattern, more than 99% of the time, baby's fine. Oxygenating fine. A reassuring pattern includes a heart rate between 110 and 160, along with adequate variability. Early and variable decelerations are normal. The caveat to that is if it's a severe variable deceleration, that is not normal. That is very non-reassuring, and you should consider at that point either doing a fetal scalp pH or just jumping right into your intrauterine resuscitation. So non-reassuring fetal heart pattern includes fetal bradycardia, loss of variability, and repetitive late decelerations or severe variable decelerations, and this is what we had here. So I would say that these three are the most non-reassuring, but there's other things that are non-reassuring. I suppose tachycardia would be a non-reassuring fetal heart pattern. Absence of accelerations would be a non-reassuring fetal heart pattern, but those are going to be the 50% usually they'll be the 50% of fetal heart tracings that are not fetal compromise. Remember, only a 50% positive predictive value. So you'll hear this term thrown out pretty often called fetal distress. And it doesn't have a real good definition, but the best definition I found in the literature was this. progressive fetal asphyxia that, if not corrected or circumvented, will result in decompensation of the physiologic responses and cause permanent CNS damage and or other damage or death. So what is the big thing we're worried about when baby's not getting enough oxygen during delivery? It's really this permanent CNS damage. And what they're referring to here is cerebral palsy. Okay, that's one of the big complications when baby is not getting enough oxygen. All right. So the management of the non-reassuring fetal heart pattern, first off, you want to consider non-hypoxic causes. Now, that can be things like anesthesia or medications, but really anesthesia and medications are not going to cause decelerations. Those are going to cause maybe a loss of variability or a bradycardia or a tachycardia. And so we can pretty much rule that out based on the fact that we have severe variables. Or even late variable decelerations, I suppose. But you want to always, late decelerations. You always want to, though, consider non-hypoxic causes first. Okay, once you've done that, you want to consider going right into intrauterine resuscitation procedures. We'll talk about that on the next slide. Like I said, some OBs will do the fetal scalp pH, but most of them are going to jump right in to do intrauterine resuscitation. After you do those procedures, you want to reassess the EFM strip. Okay, if you see improvement, that's good. Maybe continue other things with the intrauterine resuscitation. But if you don't see any improvement, then you want to prepare for prompt delivery, usually via C-section, if normalization does not occur. So what do we do for intrauterine resuscitation? The topic of our talk here. So the first thing you want to understand is that the problem is coming from the contraction. When you're having decelerations, no matter what kind of deceleration, the problem is coming from the contraction. So when it's the fetal head being compressed, that's causing an early deceleration. We don't do anything for that, but it is still coming from the contraction. You're compressing the vagal nerve, it's slowing the heart down. If you have variable decelerations, that contraction is compressing the umbilical cord, causing your variable deceleration. If you have a late deceleration, that contraction is cutting off some of the blood flow through the placenta, and that's causing a response in the fetus, which results in the late deceleration. So all of these decelerations are caused from contractions. So what do you think we want to do? Do we want to continue IV oxytocin if we're giving it? Absolutely not. Oxytocin causes stronger and more frequent contractions. So DC oxytocin to improve placental blood flow. The other thing you want to do is change position. So if the mother is trying to deliver and she's in the supine position, as they often are, you're going to have some degree of aortocaval compression. And that is going to result in less blood going to the placenta and less blood going to the maternal heart. If there's less blood going to the placenta, well, that's a problem for placental blood flow, obviously. If there's less blood going to the maternal heart, that's going to cause some degree of hypotension in the mother. And that's going to result in less blood flow to the placenta. Okay? Less blood in the heart means less stroke volume, means lower blood pressure, which means less perfusion to the placenta. And then the other thing you want to do is placental oxygenation. So you want to improve your placental oxygenation, and what you can do for this is just make sure mom is fully oxygenated. If she's delivering and she's bearing down and she's stressed out, her oxygen level is probably not going to be 100%. So what we'll do is we'll give her 5 to 10 liters per minute of oxygen via face mask and just max out her oxygen level to improve placental oxygenation. And then we want to make sure that the placenta is being perfused properly, and this is done by increasing her blood pressure by giving her bolus IV fluids. You give her lactate ringers, or ringers lactate, and you'll give her 500 mils over 20 minutes, and that helps to improve placental perfusion. Now, you have to be kind of careful with this. If she's got preeclampsia, you don't want to fluid overload her, but you're not going to get asked that in the USMLE. Okay, that's very complex MFM stuff. Okay, and then another very important thing to do is ensure the absence of cord prolapse. And you do this via vaginal exam. If you feel a cord, you want to leave it alone. Okay, because the more you feel that cord, you're going to get a vasoconstrictive reflex, and that's going to make things worse. Okay, usually if you have, well, I can't imagine an OB who wouldn't do this, but if you have cord prolapse and fetal distress, that baby's coming out surgically. So that means that one of the very first things you're going to do once you've done the vaginal exam, you've noted cord prolapse, is that once you've done intrauterine resuscitation, you want to get on the phone to anesthesia and let them know that they need to get revved up and ready to do an emergency C-section, because that's probably what's going to happen. I would say almost certainly what's going to happen if you have fetal distress plus cord prolapse. Okay. One thing I didn't put on here is that if you don't know if you have cord prolapse, let's say it's occult or there's no cord prolapse, but you still have variable decelerations, and you know that you have cord compression, is that you might consider an amnio infusion. And in this case, you're going to place an intrauterine pressure catheter. You'll place a fetal scalp electrode, so you've got really good monitoring of fetal well-being, better than what you would have with just standard external cardiotachometry. And you'll infuse 250 mils of normal saline over about half an hour, and then just keep monitoring those decelerations. And those decelerations should begin to improve, because what are you doing? You're putting in more synthetic amniotic fluid. So it's normal saline, but you're simulating amniotic fluid. And what that's doing is it's improving the cushion around that cord. And so we would expect that the cord would become less compressed with contractions. And so we would expect that those variable decelerations would improve. And so you'll go from severe, and then they'll become moderate, and maybe hopefully mild. You're still keeping an eye on this patient, but hopefully those variable decelerations will improve. You can actually go all the way up to, some say 600 milliliters, you want to stop there. Some say you can go up to a liter, but no more than a liter. But once you give those 250 mils over half an hour, you can go 10 to 20 mils per minute, and just keep watching that strip and make sure that what you want to see, ideally, is those variable decels begin to improve and become less severe and hopefully moderate or mild. Okay, in those cases, if you can get it to improve, then you may still be able to deliver vaginally. But if you don't get an improvement, that baby needs to be coming out surgically. Okay, and that's actually all I've got for you. So pretty quick lecture here. I will see you next time.